prior authorization was not invented to hurt people. In the 1980s and 1990s, insurance companies began requiring pre-approval for certain expensive procedures and medications. The official rationale: prevent unnecessary care, reduce waste, ensure patients receive treatments appropriate for their condition. Doctors supported the concept in principle. A second opinion before a major procedure seemed reasonable. In 1988, a handful of high-cost surgeries required prior authorization. By 2024, the list had grown to encompass nearly every specialty drug, advanced imaging scan, complex surgical procedure, and course of physical therapy your doctor might order. The system had expanded from an exception into the default operating mode of American medicine. The American Medical Association began surveying physicians about prior authorization in 2016. In that first survey, 92% of physicians said prior authorization delays access to necessary care. By 2022, the number was 94%. By that year, the average physician practice was completing 45 prior authorization requests per week, a figure that had nearly doubled in 6 years. Prior authorization is not administered by insurance companies directly. It is, in the majority of cases, outsourced to a category of company that most patients have never heard of, and that wields more direct power over their medical care than almost any entity in the American healthcare system. It is a company that exists in the gap between your doctor's decision and your insurance company's payment. It sits in that gap and charges a fee for the service of evaluating whether your doctor was right. The company most patients never encounter by name is EviCore Healthcare. And it was built, marketed, and operated to do one thing: decide whether your claim gets paid. EviCore Healthcare is owned by Evernorth, the health services subsidiary of Cigna. It processes prior authorization requests for more than 600 health plans covering more than 60 million Americans. When your insurer requires pre-approval for a specialty drug, an MRI, a course of chemotherapy, or a procedure your surgeon has recommended, there is a significant probability that the evaluation is not being conducted by your insurer's staff, it is being conducted by EviCore's platform. The platform processes requests through an AI-assisted review system. Clinical guidelines, developed and maintained internally by EviCore, determine the parameters for approval. A physician submits a prior authorization request. The request enters the EviCore system. The algorithm compares the clinical request against EviCore's proprietary criteria. If the request matches, it may be approved automatically. If it does not match, or if the algorithm flags it for review, a human reviewer, typically a nurse or a physician working for EviCore, is brought in to issue a determination. The criteria EviCore uses are not the same as your doctor's clinical guidelines. They are EviCore's criteria. They are not published for patients or physicians to examine. Your doctor submitting the request cannot see the exact threshold their recommendation must clear. When the denial comes back, it references EviCore's internal clinical criteria the physician never had access to and cannot specifically challenge. The system is not designed to treat your doctor's clinical judgment as the final word. It is designed to evaluate your doctor's judgment against criteria defined by a company whose income depends on the volume and outcome of that evaluation. The algorithm does not know you. It has never examined you. It has never spoken to your physician. It was written by people who work for a company that is paid to review claims, and paid more when it reviews more, and whose return on investment pitch to health plans is measured in dollars denied. In 2023, the Capital Forum obtained internal EviCore sales and marketing materials. The materials described EviCore's service to potential health plan clients using specific language, a 3-to-1 return on investment. For every $1 a health plan paid EviCore to manage its prior authorization process, the health plan would receive $3 in reduced claims that EviCore's system had declined to approve. This is the product being sold. Not care coordination. Not medical appropriateness review. Not patient safety. The product is a number, $3 returned for every dollar spent. The mechanism that produces that number is a prior authorization algorithm that declines a certain volume of requested treatments. Prior authorization was designed to eliminate care that was genuinely unnecessary. But a system optimized to return $3 for every $1 spent does not distinguish between unnecessary care and necessary care. It optimizes for the number. A diagnosis your physician deemed urgent and appropriate still goes through the system. The algorithm has no access to your physician's clinical reasoning beyond what fits in a standardized request form. It has no obligation to approve your chemotherapy or your surgery or your medication, only to evaluate it against a threshold. The Capital Forum's materials contain something else. A dial. A literal graphic showing the prior authorization approval threshold as an adjustable parameter. The dial controlled how restrictive EviCore's criteria would be for a given client. More restrictive, more denials, higher return. Less restrictive, fewer denials, lower return. The point at which your claim for chemotherapy gets approved or denied was being marketed to health plan executives as a dial. A dial they could turn. A number they could choose before any patient had submitted a single request. When EviCore's algorithm flags a request for clinical review, a physician employed by EviCore or by the health plan is assigned to evaluate it. This physician is the human check in the process, the medical professional whose involvement makes the denial, legally and procedurally, a physician's decision rather than an automated output. In 2023, ProPublica published an investigation based on internal Cigna data. The data covered a period during which Cigna physicians were conducting prior authorization reviews of specialty drug requests submitted by treating physicians across the country. In one documented 17-minute period, a single Cigna physician denied 20 specialty drug requests. That is 51 seconds per denial, per patient, per case file, per medication request from a treating physician who had evaluated the patient in person. Across the full dataset, Cigna physicians were reviewing and signing denials at a rate of 50 to 60 cases per hour. The average time per denial was consistent with reviewers spending less than 1 minute per case, including reading the patient file, the prescribing physician's clinical notes, the requested medication and dosage, and the applicable criteria, and then documenting and signing the denial. The internal process was called PXDX. Former Cigna employees told ProPublica that physicians using PXDX were presented with a queue of pending claims on a computer screen, pre-organized by the algorithm's output. The treating physician's recommendation was there. EviCore's criteria were there. The case was pre-assessed. The Cigna physician's task was to confirm or override. In practice, former employees told ProPublica, overrides almost never happened. The system was a signature. The algorithm had already decided. Federal law required a physician's name on the denial letter. The physician provided the name. Nobody told the patient that the 51-second decision was the thing standing between them and their medication. When a prior authorization request is denied, the patient receives a letter from their insurance company. The letter includes the basis for the denial, information about the appeals process, a deadline by which an appeal must be filed, and a phone number. Less than 1% of patients who receive denial letters file an appeal. The reasons are not mysterious. Filing an appeal requires time, medical documentation, repeated phone calls with insurance company staff, and often assistance from the treating physician's office, which is also being asked to spend uncompensated time on administrative follow-up for a decision they did not make and do not control. Patients who are sick, who are working, who are caring for children, who are already managing a frightening diagnosis, are being asked to become administrative advocates for themselves at precisely the moment they have the least capacity to do so. Many cannot. Many do not know they can. Many try, wait weeks for a response, and abandon treatment they needed while they wait. Among the patients who do appeal, more than 35% have their denials overturned. A 35% overturn rate means that more than 1 in 3 contested denials was clinically wrong. The algorithm evaluated the request incorrectly. The physician spent 51 seconds and signed incorrectly. The treating physician's clinical judgment, formed after years of medical training, a physical examination, and a review of the patient's full history, was overruled by a system that got the answer wrong at least a third of the time when anyone pushed back. The 99% who did not push back received the same denials. Their treatments were delayed. Drugs went unfilled. Procedures were postponed. The American Medical Association's 2023 survey documented the consequences. 93% of physicians said prior authorization had caused a delay in care for a patient. 24% said prior authorization had led, directly, to a serious adverse event, hospitalization, permanent bodily damage, or death. In February 2023, ProPublica published the investigation How Cigna Saves Millions by Having Its Doctors Reject Claims Without Reading Them. The story described in detail the PXDX system, the 51-second review process, and the gap between the company's public statements about clinical rigor and the internal data on how quickly claims were being processed and denied. The investigation was based on documents obtained from former employees and internal Cigna data. The Senate Finance Committee opened an inquiry. Senators requested documentation from Cigna and EviCore on denial rates, review times, physician caseloads, and the criteria used in their prior authorization systems. Cigna's response maintained that all denials were issued in accordance with proper clinical protocols. In October 2024, a class action lawsuit was filed against United Healthcare alleging that the company had used an AI algorithm developed by a subsidiary called Navi Health to systematically deny post-acute care coverage for elderly Medicare Advantage patients. The algorithm, called NH-Predict, generated a predicted length of stay for patients recovering in skilled nursing facilities. When treating physicians determined patients needed more time, United Healthcare denied coverage in alignment with the algorithm's shorter prediction, regardless of the physician's clinical assessment. The lawsuit alleged a denial rate exceeding 90% for patients whose physicians had documented medical necessity for continued care. In December 2024, United Healthcare CEO Brian Thompson was shot and killed in New York City. In the days that followed, the phrase printed on the shell casings, delay, deny, defend, became the most searched health insurance term in the United States. The three words referred to a documented insurance industry strategy for minimizing claim payouts. They had been in policy research for years. In 1 week, they became nationally understood. No prior authorization algorithm was dismantled. No EviCore dial was adjusted by law. No criminal charge was filed against any insurance executive for any denial. Here is the math. 1 in 3 Americans with health insurance have had a claim denied, delayed, or modified by their insurer. Less than 1% appeal. 35% of appeals succeed, which means the denial was wrong. Which means, for the 99% who did not appeal, the algorithm's error was never corrected. The treatment stayed denied. The medication stayed unfilled. EviCore's parent company, Evernorth, reported $62 billion in revenue in 2023. The prior authorization management business, the business of running the algorithm that reviews your doctor's decisions and generates $3 in denied claims for every $1 spent, contributed billions to that figure. Cigna settled a Department of Justice investigation for $172 million in 2022. The investigation concerned fraudulent risk coding that inflated government payments. The penalty was less than 1% of Cigna's annual revenue. The ProPublica investigation of the 51-second denial process resulted in zero financial penalty. The EviCore dial, the mechanism that allows health plans to configure how many of your claims get denied, has not been made illegal. Your physician spent years in medical school and residency learning how to treat your condition. They examined you. They ordered tests. They reviewed results. They chose a drug. They submitted a prior authorization form. An algorithm built by a company that charges health plans for denials compared your physician's request against internal criteria you were never shown. A physician working for that company spent 51 seconds reviewing the Q summary. The denial was signed. You got a letter. You had 30 days to appeal. 99% of people in your position did not. The algorithm moved to the next case. That is the receipt.